uncommon cataract. It is autosomal dominant, usually associated with weakened or absent posterior capsule, and it is associated with high incidence of PCR, say as much as 26%. So cataract surgery in all such cases is a challenge. Clinically, posterior polar cataract is of two types, stationary and progressive. Stationary presents with a well-defined plaque, and it varies in size among the individuals and among the eyes. No other part of lens is affected. It is more common and it is associated with remnants of highlight system like Mettendorf rods. Progressive type, it consists of a posterior plaque initially, which later develops posterior cortical extensions with punctate cortical opacities. These are four types: round or oval with a ring corneal onion appearance. The second one is associated with posterior subcapsular cataract. Type 3 with dense white spots at the edges, and type 4 with all the above combination with nucleus sclerosis. A circular hazy ring just behind the concavity of posterior capsule on slit lamp examination is suggestive of posterior capsular opening. Relatively young patient present to us with glare and blurring, difficulty in driving at night, difficulty in working outdoors, and difficulty in working on systems, and they have difficulty in reading small prints. Still, the patient may have 6/6 visual acuity. Surgical principles: assume that the posterior capsule is absent, and we should ensure that every maneuver is premeditated to avoid the complications like enlargement of the tear, the disruption of the vitreous phase, and a dropped nucleus. The anterior chamber has to be stable, and the BSS inflow should be non-turbulent. AC collapse has to be avoided. There should be no hydrodissection, only hydrodelineation has to be attempted. Making of tunnel and side port is similar to a routine ascites cases. Care has to be taken in the following steps: rhexis, hydrodelineation, nucleus prolapse, epinucleus and cortex removal, and IL placement. Slide it again. Okay. Now, capsule tends to be more elastic in younger eyes, and it may lead to a wider CCC than anticipated. So, always use a high viscosity OVD. You should aim for a smaller capsular opening than what is actually needed, and you will get a CCC of desired size. CCC of about 5.5 to 6 millimeter is of adequate in size, and to avoid nucleus drop, do not overinflate or over-pressurize the anterior chamber with the Visco. No hydrodissection, as the pressure from the fluid collected behind the nucleus may burst open the capsule, and the fluid wave may split the localized adhesion at the posterior capsule, creating a hole which may cause vitreous herniation and nucleus prolapse. Hydrodelineation has to be done in a slow, gradual and controlled manner to create a controlled cleavage of the inner nucleus from the epinuclear plate. The hydrocannula is inserted into the plane away from the height of the posterior polar cataract, so that the wavefront is created and the posterior capsule is not ruptured, and you see a golden ring reflex. You should avoid sudden gush of fluid. You should maintain steady pressure on the syringe. Do not over-hydro or vigorously visco-dissect. It may perforate intact but abnormally thin central posterior capsule. You can see how gradually we are injecting the fluid. Nucleus prolapse should be done as gently as possible with minimal stress to zonules and the capsule. The rotation is to be done carefully after injecting Visco. Nucleus is slowly lifted from the epinuclear plate using the Sinski hook or with the help of Visco cannula. And for softer nucleus, you can do with the help of Visco expression. And for harder nucleus, you can use a phaco sandwich technique or the vectus removal. You can see this hard cataract is having a posterior polar cataract. So whenever we are performing surgery in hard nucleus, you never know there is a posterior polar cataract sitting behind, and we may rupture the capsule if we do hydro. So never do hydrodissection in case of Grade 5 nucleus. Avoid hydrodissection. Epinucleus and cortex removal. A dry aspiration has to be used using a Simcoe cannula. Visco is injected into the anterior chamber and the capsular bag. Peripheral parts of epinucleus and cortex are engaged and gently loosened and removed in a circumferential manner until the central plaque of epinucleus and cortex remains. The central attached portion of the posterior polar plaque is removed last by gently teasing away the posterior capsule using the Simcoe cannula by dry aspiration. We are removing the peripheral part, making it loose, and in the last we'll tease the central part. In case you require, you can make a second side port to remove because it is drier aspiration, so it is not as easy as the routine Simcoe aspiration we do. See, now almost all 360-degree epinucleus and cortex are dislodged from the periphery. If the central plaque of cells which remain adherent to the posterior capsule after the removal of the cortex, you can just leave them in place. No aggressive movement is advised. Avoid pollution of central portion because the capsule is thin and it may give way and it may open easily and you may land up in problem. Central scarring if present, you can do a posterior capsulorrhexis or you can wait and do for NDR capsulotomy later. Once the plaque is aspirated, always examine the posterior capsule. Sometimes you may find a posterior hole in the PC with the intact hyaloid face. In such cases, just use Visco to tamponade the vitreous, and if the hyaloid face is broken and vitreous presents through the rupture, you can perform a dry vitrectomy. For vitrectomy, we use the setting of about 700 to 800 cut rate with 100 to 150 vacuum. If there is a radial tear, small tear, and if you are able to perform a posterior capsulorrhexis, it is advisable. Avoid flattening of anterior capsule, particularly when there is a hole, because the tear may extend and the vitreous may herniate. In cases without a hole, the capsule may be thin and spontaneously rupture if the AC is flat due to the vitreous pressure against the capsule. Always try and inject using the side port. Inject the Visco using the side port to maintain the anterior chamber. IOL insertion again has to be slow and gradual even if there is no break, because even the slightest force on the posterior capsule may be enough to cause a break. A 6 to 6.5 optic size IOL is preferred. If PC support is not adequate, IOL should be implanted in the sulcus. With care, patience and proper technique, posterior polar cataracts can be managed safely in manual ascites. Thank you.